prospective, randomized, double-blind comparison with treatment rounds, and administered over 2 different times intervals.
Okay. Thank you very much, and I won't repeat that. We all know that post-operative rehabilitation is a major factor in the success of anterior cruciate reconstruction. But little is known about how much activity promotes effective healing versus that which leads to damage or failure of the graft. There's obviously been a recent trend toward rapid rehab with return to sports within 4 to 6 months, and some folks are advocating even more quickly. And this appears to be successful and is almost universally accepted. Yet no randomized clinical trials have yet proven that rapid rehab and early return to sports, that is in the 3 to 4 months range, is truly safe or efficacious compared to more conservative approaches. And too frequently, undesirable joint kinematics reoccur in the form of either pathological or abnormal anterior translation of the tibia relative to the femur following these procedures. Don Shelburne, for instance, in his famous paper that really started all this, in a 2-year follow-up, 25% of his patients had more than 3 millimeters difference in laxity between the two knees on anterior translation of the ACL. So there's really little information available to the clinician which allows them to identify which of those rehab activities are really safe and when we can be instituted without being overly aggressive. We know that healing tissue must not be overloaded. They must be stressed at the proper amount to remodel appropriately, but the problem is no one really knows what that amount of stress and load is. The goal is to understand that the relationship between rehab and the rehab exercises and the biomechanical and biological response of the graft and the ultimate outcome of the ACL reconstruction. That's something we know very little about. 20 years ago, casts for more than 6 weeks used to protect the healing ACL after reconstructions or often in those days repairs. But the ill effects of immobilization is identified in looking at animal models to all the structures listed there. Early advocates of post-operative motion include our moderator, who isn't here, and Frank Noyes in the 70s and 80s. But the really famous star to all this aggressive rehabilitation, as it's now called, was Smith Sheldon's paper in the American Journal of Sports Medicine in 1990. ACL reconstruction, non-randomized clinical trial of accelerated versus conservative rehab at 36 months, found that the anterior laxity was 3 millimeters or less in 87% of those with a conservative treatment and 80% with the accelerated. But there was no significant difference in these outcomes. However, the accelerated group produced a good deal of increased synovitis with frequent need for aspiration, and so they had to slow some of these people down. Now, several groups, as you see listed here, have produced randomized clinical trials concerning rehabilitation activities and their effect on outcome, and primarily including the anterior laxity. In a one-year follow-up, Bynum found that early institution of open kinetic chain exercises produced increased anterior laxity compared to closed kinetic chain exercises begun at the same time. Mickelson in Sweden, with one of Wiener's associates, found that 1 year that closed versus open kinetic chain exercises started at 6 weeks really made no difference in the final anterior laxity and follow-up. So a little different outcome. In this study, closed versus open kinetic chain exercises started at 2 weeks, no difference in gait analysis and knee laxity after 4 weeks of training. This study, it looked at the difference of the amount of rehab and the number of days done, and you can see that the folks that did the more aggressive and longer activities, when they were followed at 1 year, had better position sense, better lease-on scores, and earlier return to work. In a pilot study for the one I'm presenting here, our group demonstrated that exercises, we used a model of instituting exercises over different intervals based on the amount of strain produced, within the normal ACL, and found no differences in EP laxity at 2 years, and an IKDC clinical assessment, the KOOS score, only the top test, and markers of cartilage metabolism, both degradation and acceleration, and the Tegner activity scale. We used biomarkers, cartilage metabolism, including these big words that I'm going to try to read to you, looking at collagen degradation, collagen synthesis, and ground substance aggregate turnover. And here's the complex flow of the biology of collagen. You can see in red these markers that we were looking at here. And what we found in this one, this is the biomarker for cleavage of type 2 collagen, that is collagen degradation. The gray bar is the controls. The non-accelerated group is the white, and the red is the accelerated group at time 0, the day of the surgery. And then you can see that there was an increase, but it wasn't significant, of the accelerated group. And by a year, they were back to normal, but it took a year to get there. And this is a little more alarming, because this is the biomarker of synthesis of collagen. It's upregulated, and it's upregulated at the time of the surgery. There's no difference in the two groups, the non-accelerated and accelerated, but this is not returned to normal at 24 months. And this is many months after almost all of us would allow an athlete to go back to vigorous activities. And this is the biomarker for the synthesis of aggregan. And here again, you see that it goes way up with both groups acting the same. It's still way up at a year, and it's getting back to normal only at the 2-year follow-up. So both the accelerated and non-accelerated rehab protocols produce increased synthesis of type 2 collagen and proteoglycan. And both programs appear to affect the cartilage metabolism similarly, but the fact is there were quite a bit of changes that took a long time to recover. So in the study I'm presenting now, the design is a prospective randomized double-blind study. It's a 2-year follow-up. And the primary hypothesis is there will be no difference in EP laxity in the reconstructive knee between the two rehabilitation protocols. And the secondary one is that there will be no difference in these activities that you see listed here. So this is a typical randomized clinical trial. We gather the data, do identical ACL reconstruction, and in the immediate postoperative period, their stratification and randomization into the two rehab groups. The pre-operative exclusion criteria were any previous surgery on either knee, less than 18 or older than 50 years of age, any interarticular fracture, greater than grade 2 laxity of any other ligament, pre-op Tegner activity of 4 or less was not put in, of course, and radiographic evidence of arthritis or prior significant injury to the collateral knee were excluded. Interoperative exclusion criteria included an ACL. A couple of occasions it was felt we were going to reconstruct it, but found that it wasn't bad enough to do that, so those were not done. Any exposed bone, that is grade 4 cartilage lesions, a meniscus that required repair, or more than 50% of the meniscus being removed were disqualifiers at the time of surgery. Between December 98 and May 01, we had 390 patients who underwent surgery with the intent to reconstruct the ACL. The 170 failed the preoperative inclusion criteria I just gave you, 12 excluded at the time of surgery for those reasons. So 208 were eligible, but 166 elected not to participate, and 42 were enrolled. Our pre-op power analysis revealed that 20 in each group would be adequate. Of the 166 who elected not to participate, some lived too far away to be involved in the rehab protocol. Some felt the study would be of benefit to them and didn't want to do it. Some didn't wish to return for follow-up, especially when they learned we would be aspirating joint fluid from them. They preferred one rehab program over another and elected not to enroll. The procedure was a 2-incision arthroscopically assisted central bone patellar tendon bone graft, fixed in both tunnels with titanium screws, and grafts for tension manually. Interoperative KT1000 arthronomer measurements were done. We established immediate post-interoperative laxity, and if that laxity was greater or less than 1 millimeter different from the opposite side as measured post-anesthesia, intra-surgery, the grafts were retention until we made that amount of tension. They were then randomized, as we said, into the two groups. This is done by a random number generator. Neither the patient nor the examiner knew the result of the randomization. This is administered by the same technician, and compliance was verified by daily log and weekly interviews. Exercises were performed 3 times per week under the supervision of a physical therapist, and they were performed on the other 4 days as per the protocol. Now, both the accelerated and non-accelerated rehabilitation protocols had common activities. Range of motion, amount of weight bearing, type of exercises were all the same. The real difference was these activities were incorporated at different times in the 2 programs. And we based our decisions on which activities to start early, the aggressive one late, and the more conservative one by measuring strain on the anterior cruciate by the small strain gauge device that we had done in vivo, with many studies published in the late 80s and 90s to get these into the 2 protocols. And most of the activities were not particularly different, but you can see in just an example, active extension of the knee from 0 to 90 degrees with resistance was not allowed until 12 weeks in the non-accelerated, and was started here in the accelerated. You can see the differences listed here. There were, I can't remember, there were like 45 different other activities, but I didn't put them all up there. And some of them are pretty much the same because they don't endanger the ACL with increased strain. Then we followed at 3, 6, 12, and 24 months. At all sessions, we had a KT1000 measurement, and of course, we didn't do a one-legged hop under operative, which are the ones that we didn't do at that one time. We used 2 factor repeated measures analysis of variance and the difference between programs over time and how each program changed over time were observed. And actually, I said earlier that it was 20, but it was 15. I'd forgotten that we had to have in each group to have an 80% power with an alpha of 0.5. We found no difference between groups depending on their gender, height, weight, age, operative findings, concomitant injuries, intervals between injury and surgery, and pre-injury activity levels. They were all the same. You can see that they were nearly the same in age and weight. Males were more in the accelerated group, the way it was randomized, and you can see the differences right and left here. Days between index injury and surgery, mean range is very similar. Now the results of the 42 patients enrolled, total enrolled for the investigation, 24 were randomized to the accelerated, 18 to the non-accelerated, and you can see that there were some dropouts and failures, and the number of subjects ended up being 19 for the accelerated and 16 for the non-accelerated, with a reasonable retention at the end of the follow-up. Meniscal lesions were similar, and meniscal debridement or resection as well. Remember, we eliminated any repaired in this guy, and there were no injuries to any of the collaterals or the PCL, and the comorbidities were really very similar. Now, this is a busy slide. The yellow is the long program. This is 100% compliance in the rehab, and even with this testing and plotting them on, you can see that there was drop-off with time. And I think this is something that most papers don't even think about. It's sort of use a rapid rehab, modified program, and they don't tell you anything more about it. And I can tell you that unless you're really kicking it, and it's going to need worse than this in terms of compliance following the procedure. Now, we did use radio stereophotogrammic, if I can say it, RSA analysis, because we were concerned about the accuracy of the KT1000. This is a very complex program where small beads are placed within the bone at the time of the surgery, and then stress testing is done in a very sophisticated manner to measure exactly, actually, we're a 1/10 of a millimeter with radiographic technique. And suffice to say that because we can't measure pre-op and only post-op, there was time, the total range of motion in AP was here, and you can see there was a little increase as time went on. But this was no different, in fact, from what we saw with the KT1000 measurement. Here we get the pre-op laxity, this is just anterior. Here we got it within 1 millimeter of difference between the opposite side, and you can see that between 0 and even 6 months it was a little increase, and then it flattened out. And there was no difference between the two treatment groups. So we determined by the two methods that there was no difference. Both groups significant increase in the laxity over time, but they were still under 3 millimeter side-to-side difference in 2 years. No difference between the two groups at baseline or 2 years of follow-up. Both groups changed similarly over time as far as the IKDC score was concerned. Both groups improved from baseline and final outcome. You can just see, here's the tenure scale. I still don't quite understand how we got them to improve, but you notice they're reasonably low. Anybody below 4 we didn't start with, so anybody that was not active wasn't with the study. But you don't very often see scores returning at any time afterwards, and I really don't know how to explain that. That's what we found. But realize it's only up to a 6, not up to an 8 or 9. The KOOS, which is the knee osteoarthritis outcome score that was developed by a colleague in Sweden, we found no difference between the groups and no treatment group time interaction. The 2-year follow-up, the scores in this system approached 100, which is returned to near normal values. There was no difference between the two groups. One-legged hop test, and each group responded the same way, as you can see here. Pre-op difference, obviously it was very poor at 3 months in both groups, but you can see there really wasn't much difference at 24 months, so really any time interval along the way. I'll just skip through those. The strength of the hamstrings and quads, there was no difference between the treatments, and the subjects improved at similar rates. This should be accelerated here. And you can see that the injured knee obviously was below the uninjured knee, but it returned to near normal in 24 months. And although there's a little difference, this is injured, non-accelerated, and normal non-accelerated. The curve's a little lower, but you can see there's no statistically significant difference between the two. We looked at proprioception. In this case, the threshold of detection of passive motion was similar for both sides. We had a sophisticated way that the curve came down, and we'd inflate the airbags and then slightly move them, and they would push the button when they reached the feeling that the knee had moved. And there was no difference in the threshold of detection of this passive knee motion by either treatment group over time. Now, this is the one that I would like to be able to tell you we have available, but we're still in the process of looking at these. We did draw fluid at 3, 6, 12, and 24 months, and it's not really very much fun to be the guinea pig for this. And patients were very game to stick it out, and we were worried that we would lose more than we did once we got this done without anesthesia. Now, our studies revealed that the rehabilitation programs did not produce any differences in any of the parameters that were measured. We found that the RSA measurements confirmed that the KT1000 measurements were reasonably accurate, assuring us that there was no difference in anterior knee laxity by either method. I can tell you, using an RSA program is difficult, and I'm glad to see that this is the case, so KT is a reasonable way to do this. The increase in anterior laxity we observed in both groups is not explained by the differences in the rehab protocol. It did appear between time 0 and 3 months, but it flattened out by 6 months and left the knees in the nearly normal category or better. Our study does not imply that more aggressive rehab starting earlier or more vigorous activity would not result in worse results. A more aggressive program has in fact been critiqued or criticized as still being quite conservative. In our early pilot study, we found that as Majima and Sapporo had observed that attempts to perform vigorous quadriceps activity earlier than 1 week result in pain and infusion, and are difficult to continue. Even with close monitoring, compliance with rehab protocols is variable and diminishes over time. And although compliance was similar in our two groups, assuming compliance is as high in other studies where monitoring is not reported or really looked at, may result in findings that are unreliable. I question the article that says we used an aggressive rehabilitation protocol and that's it. We need more details. The equivalent clinical, functional, and patient-oriented outcomes between our two rehab protocols leads us to recommend a more aggressive rehab protocol. And I must admit that I've always been pretty conservative, and so with this, I switched down to from 8 months return to sport down to the 6, but I'm still a little nervous about 3 or 4. Our study does not condone the use of accelerated programs that are more aggressive than those we studied. And like I say, we were critiqued about this as not being aggressive enough, but I think it's a matter of ethical, cutting it down to the point where we're going to hurt the patient. It doesn't allow us to be any more aggressive than this. I realize that this is a pretty heavy topic for most of you interested in skiing safety, but I do appreciate the opportunity to give the paper. Thank you.
Please open discussion from audience. Right? Back, please. Any question? Yes. Hello. Have you ever tried doing anything? These rehab programs with hamstring tendons?
No. In fact, there is no study in near this equivalent of hamstring studies I'm aware of. We have not used that as our primary method, and we have not done that study. This is just bone intelligent bone.
Anything wrong with hamstring studies, or is that topic?
Well, I'm retired, yes, and I personally am not. I still think that in my hands this is the way to go. I feel like there are enough disadvantages to hamstrings that I personally probably still wouldn't switch to them. I have nothing against them, but I think there are some problems that are not. I don't think taking out the hamstring away from with the synergistic the ACL makes sense for any athlete. Okay. But I realize, I don't think we can say that bone patellar tendon is bad. Anything that's published, nor vice versa.
No question? Any more question? Our previous research indicated the second group and the second evaluation indicates to early rehabilitation program and the partial rupture of the reconstructive tissue.
You saw partial rupture with early aggressive protocols.
But in 2000 evaluation not different. Two groups, partial tear, good result. Second group, evaluation.
Okay. All right. Well, I think the second look is good, and it's one way to determine the status, but you still don't know for sure. But the quality of what you see there looks pretty good. It still may be far from normal. Being able to produce normal kinematics, and I think that's why we see these 2 and 3 millimeter side-to-side differences. And I'm not sure that we're really where we want to be with that. Those should be equal, not 2 to 3 millimeters different, even if they look better. Okay?
Any more questions? So, move on next paper.
Okay.
So,
well, I hoped I wouldn't quite fill a half an hour with the first paper and maybe take a little more with this one, since I think this would be a bit more interesting to most of you. So we're looking at injury trends and risk factors involving ACL injuries in alpine skiing. This is based on our 32-year case study that you've heard about many times. We looked at the population, as you know, evaluated each injured skier, the demographics, experience, information concerning injury mechanism, diagnosis, and treatment by orthopedists at the Base Lodge Clinic, and actually doing the same type of testing on a group of at-risk patients, knowing that population in great detail. So to do this, we have to have the number of people on the mountain. We have a very complex way of doing this because season pass or ticket sales are not the only way. In Europe, where you have a counter with each lifted, is, I think, an excellent method that we don't have the opportunity of doing. I don't think I have to explain MDBI to you. We've heard that many times here. The objectives and methods of the present study is to monitor the trends of incidents of ACL injuries and other major injury groups that sustained at our ski area over those 32 years. And many of these won't be the whole 32-year period, and we'll try to point those out. And what we want to do is to identify risk factors associated with ACL injuries. The groups that we'll compare are these. Control, Mark, this is where we separate these out. Isolated ACL, where there is no other apparent significant injury to any other structure, maybe the menisci, but no other ligaments or capsular structure. ACL grade 3 with a lesser degree of NCL, grade 1 or 2 MCL sprain, grade 3 ACLs with a lesser degree of LCL sprain, and another category which appears to be quite different, as we've said yesterday, the MCL grade 3 and ACL grade 3. Then we look at isolated MCLs, isolated LCLs, lower leg and twist and bend, and in some cases combined. And then all other injuries, every injury, including some in the upper femur, hip area, but mostly upper body injuries is the all other injury group. And so it sort of goes like this. We're looking at knee injuries and below. This doesn't show the all other group, but we have knee sprains. We have grade 3 ACL, and the 4 groups of ACL categories as I've stated here. The other minor injuries to the LCL and MCL. And this little dotted line indicates that these act more like MCL, LCL injuries than these. And then the lower leg. You saw the difference between the twist spiral fracture, bending, yoke cord ruptures, and boot top transverse fractures and such. We looked at these with chi-square Fisher exact and regression analysis were appropriate. This is based on the same data that we'd seen a couple of days ago. We noticed that in 1973 through 5, the first 3 or 4 years of the study, knee sprains were first. They're still first in the last 4 years, but you can see these have dropped way down to very distant numbers. And we all know how this has changed by several of the studies that we've heard this week. We know that the injury rate decline overall for all injuries is down 52%, 123, 31, or 231. Now we have to have almost 500 to get a single injury. And this is the all injury curve. It's definitely gotten better. The risk of injury is about half of what it was 30 years ago in our study. We're looking at lower leg injury decline. This is all lower leg injuries. As you can see, this has improved even more, an 83% decrease. Since year 17, this is year 32, the risk of sustaining a twist-related injury has increased by has decreased. Is that right, the way through? Okay, I'm sorry. It looked wrong to me. This 13-year trend has reduced the net improvement in twist injuries from 90% if it had gone on and what it was in the middle of the series down to 81% now. I confused myself, I'm sorry. This is what the twist and bend injury curves look like. It improved up till this year 17 area where it seemed to inflect and go down. In fact, the twist injury is a significant worsening as that one goes down. Things get worse. Now, factors which may influence the improvement in lower leg injuries during that first 17-year trend include these. Reduction of friction between the boot and ski, improved binding performance under combined loads, lower release settings, better equipment maintenance, improved boot design, improved fitting, increasing experience, and improved trail grooming have all been indicated as reasons for that. But what has influenced the failure to continue to improve the lower leg injuries in the year 18 up until, in this case it says 30, should have said 32, an overall decline in the standard of care involved in binding installation, calibration, and maintenance seems to be one of the possible factors. The introduction of ski boards with non-release bindings certainly has had an effect. A decline in the standard of care of boot fitting and the increasing popularity of terrain parks all may be factors. Yeah, knee wreck. Old film, but you can sort of see this guy's got his leg in there. Now, looking at knee injuries, this is all knee injuries out of the almost 1,800 total knee injuries. You can see that sprains account for 25, almost 26% in this ongoing study, and all knee injuries add up to 34%, or 1/3 of all injuries that occur. The risk of sustaining a minor to moderate knee sprain declined by 70% over 30 years. However, the risk of sustaining a serious knee sprain increased by 250% through year 20. Since year 20, the risk has declined by 29%. So this is what I showed yesterday. Grade 1 and 2, both MCL and LCL in here, it's improved. This was the bad news for ACLs. All grade 3 injuries, 95% or more are ACLs, down to this inflection here where it seems to have improved at a significant level since then. Now, ACL injuries themselves account for the most of all the injuries now, 24-30. You can see that the most common injury in the old days was dropped in second place. A total of 2,430 ACL injuries, and 13% of all injuries, 52% of all knee ligament injuries over the entire study. But you can see that ACL injuries by groups of 4 here had increased, and there was the inflection that really showed up in our mind was around year 82, where we started to see it get up to this level. It peaked here, and appears to be dropping back, as we've said. The risk of sustaining a knee sprain involving the ACL increased by 231% over the period from year 3 to year 20. Since year 20, there's been a 34% decrease in the risk of ACL injury, which we reported at Pontresina for the first time was a significant improvement. And here's that total curve. But it didn't show up until we got these last couple of years in here to show that this curve, when you best fit it, a method that only Jake could explain to you, show this improvement. Now, the possible reasons for the increase in ACL sprains over that first 17 years was obviously increased boot stiffness, backward lean, making the fan foot mechanism more likely, changes in ski design that improves the turning, and increasing age of the skiing population. Possible reasons for the decrease in ACL sprains over the last 10 years or so is modification in skier behavior due to ACL awareness program, we'd like to think, but I don't know that we can really take credit for that as a reason. It's possible, but not a lot of people that are non have ever heard of it. We asked them all after they've been heard. Changes in skiing technique, shorter skis, more experienced skiing population, and reduced number of falls per day, especially the last 6 years. As you know, we don't feel that changes in binding design function has been a factor. Now, some other results. Gender, if you look at the all other injury group, it's 60-40 male-female. Controls, the uninjured skiers are 60-40, but you can see in here with all ACL group, the females predominate. The risk of any knee injury, including MCL, LCL, for females is approximately 2.5 times that for males. Females are 40% of the control population that suffer 63% of the ACL sprains. The risk ratio for women sustaining ACL injury in comparison to men is 2.5 over the 32 years, and you can see that it's about 2.5 here through the most recent years, pretty much matching the percent of injuries that I've given you previously. Height and weight. Skiers sustaining ACL injuries are shorter and lighter than controls. and those in the all other injury group, and skiers sustaining bending injuries to the lower leg. Skiers sustaining ACL injuries are taller and heavier than those in the MCL and LCL group, and in the twisting lower leg injury group. Ankle sprains, fractures, and tibia fractures in that particular group. Oops. Age. ACL injured skiers are older than all other injury groups and controls. Self-estimated skier ability scaled from 1 to 5 by this 5-member group. And you can see that the people that were most skilled were in the control group, and sort of categorized by decreasing skill level as we get over here. You can see that the MCL, ACL group is over here, both grade 3s, MCL is here, and ACL 3, which is not including these, all the other ones are in the middle here, 3.2. So there is a difference in ability, as you see by that scale. If we look at experience, totally skied, all injured groups had less total experience than controls. Skiers with least total experience included MCL, ACL, MCL, and LCL. Twist and bend lower leg injury. Skiers with intermediate total experience included isolated ACL, ACL with lesser degree MCL, ACL with LCL, and all other injury. Skin structure. Lifetime, either 10 or more hours, 1 or more hours of instruction within the season the injury was sustained were evaluated. And we found no evidence that injury risk was reduced for sustaining any of our lower extremity injury categories compared to controls. Speed at the time of injury wasn't different for any of the groups. That was self-estimated speed, of course, by the skiers. Here's a finding that we reported several of these meetings ago. There is a difference in left-right incidence, and you can see that there is a left dominance by 35% in the ACL injury group, whereas there's no difference in MCL injuries right versus left, and no difference in lower leg injuries of all kinds. Don't know why that is. I can't explain it. Grade 3 ACL injuries last 24 years. Left over right dominance, and you can see that there is a difference here in all these groups, but again, the MCL, ACL seems to be a category that isn't the same, as we've said for some of the other findings. Helmets. Obviously, we were in Norway. This one is amazing. Use of the helmet, yes or no? Percent involved. All other injuries, 21%. Controls, 22%. Total ACLs, all ACL groups, 11%. And then, of course, you see the difference there. Helmet use is 50% lower than expected among those sustaining an ACL injury in comparison to all other group or to the control group. This is hard for us to understand. We try to control for it against sex, age, and skier type. And helmet use remains underrepresented in the total ACL injury group even after controlling for these at the 0.05 level. You explain that one to me. And here, we still advise you to wear a helmet. I'm not quite sure that you can relate cause and effect here, but this is an interesting finding that I hope some of you can help us eventually explain. Helmet use results for other knee and lower extremity injury groups are not statistically significant, just the ACL category. I don't understand. Oh yeah, we just said you should wear a helmet, but you missed it. Falls. The objective here was to determine the difference between falls experienced during ACL injuries compared to lower leg injury. This has been a very frustrating analysis for us because it's very difficult to get the skier to tell what happened. And we don't very often have a film of it occurring. In 1,329 cases we selected where the skier reported that the injury occurred at the time of the fall. determined whether the leg injury occurred on the uphill or downhill leg. They knew we could do that because they could reliably tell us that they were traversing right or left during the fallout at the time of the injury. And determined whether injured leg was rotated inward and outward. That they seemed to know. But the direction of fall relative to the body, direction of fall relative to the fall line, and whether the leg injured was weight bearing at the time, we know from an analysis of watching people fall and intercepting them right afterwards and asking, they can't tell you that accurately. From this, for the lower leg, uphill and downhill involvement was nearly equal. For the ACL injuries, the downhill leg predominated. And as you can see here, the downhill leg was greater in this group than it was in the lower leg group or these other groups at the .06 leg. For lower leg injuries, inward and outward rotation was approximately equal. For ACL injuries, inward rotation predominated. Well, this is, I don't know what happened there. But the point is, these seem to go along with the fan foot protocol and Buddha's injury mechanisms. And they are very different from the profile from the lower leg injuries. But it was very frustrating not to be able to use all those questions that we worked so hard to get answers from the patients. The percentage of bindings that did not release during an injury event. As I remember, Mark, you showed a much higher, a much lower number. But the point is, they report that the release occurred at the time of injury or afterwards. This is what we found for ACLs, and I think that in our mind, this still indicates that loads to the release system are generally inconsequential during an ACL injury, and there is thus no need for release, based on what we presented yesterday. ACL injury more likely to occur before the fall than any other injury group. In other words, they're hurt before they even realize that they're going to fall. Not infrequently, but you can see that the numbers are much less for the other injury groups. An ACL injury can be the event that leads to the fall. ACL injury is least likely to result from collisions, as you see here. This means collision with the snow, not with another object. Number of falls per skier days is declining. Injured plus control skiers. In the early days of the study, the average skier fell 4 times. Now, we only report 15, or 1.5 per day. And we can then play around and get mean falls between injuries if we wanted. All injuries in 72,900 mean falls between injury. And you can see that lower leg injuries, as you would expect, have gone up because they improved, and ACL injuries have gone down because they did not improve. Ski length. In the last 12 years, when ski boards became available in our area, ski boards represented only 1% of the equipment in use and 0.9% of all injuries, but they accounted for 7.2% of the twist injuries to the lower leg. The median length of ski boards in the study was 54% of the skier's height, and the range from the second to the 98th percentile was 40% to 70% of the skier's height. No ACL sprains were sustained on ski boards, although the expected value compared to the rate that we would see in other alpine skiing should have been 11, and that was significant. Ski board injuries for the other injury groups range from, as you'd expect, around 1%. They didn't increase the other injury groups. Now, ski length less than 75% of the skier's height, or less than 5 times the skier's foot length, are unlikely to produce an ACL injury. During the last 12 years, only 4 out of 1,098 ACL injuries occurred on skis less than 75% the height of the skier. Ski length, you can see as it gets down around 75%, the percent of ACL injuries less than expected gets very high. This breaks down at about ski equal to your height. ACL injuries are not related to the quality or function of modern release bindings. The release systems, which are the bindings, and lower leg fractures and sprains, are related to the release system's quality and function, and we think the data we've just given you continues to support that. In conclusion, ACL-injured skiers are shorter, lighter, older, more likely to be female, and less skilled and experienced than the controls. Sounds like a preacher. ACL-injured skiers have very different fall profiles than skiers sustaining lower leg injuries. ACL injury unlikely at ski length is less than 75% of the skier's height. The unexplained findings that we need help on are left knee dominance for ACL injuries, and we don't see them for any other knee injury or all other injuries. This apparent atonement effect we can't really expect to be causal, but it's an interesting finding that we've tried to eliminate, but we can't, and we present it to you with a big question mark on it. Thank you. Thank you.
Thank you, Bob. Right, please. Any question from audience? Oh, yes.
Regarding the left leg dominance, Bob, do you ask them which leg they kick a football with, or which side they feel stronger turning towards? Could that be related?
Well, it could be, but we didn't ask them that. We asked them, do they feel they were right or left dominant? Right. Not kick, or do they feel better? I mean, the explanation would, you could easily say, well, you're more likely to injure your non-dominant side. It's about, in our data, and in the population in general, it's about 11-12% are left-handed. But it doesn't, that effect doesn't go over to any other injury, not even to the other knee injury groups. So I can't explain it. The only other place I know of it, and I'm not sure if this is true of the rest of the world, but in one large study in Sweden, down in Linköping, they found a left dominance in soccer. I don't know of any other injury groups that are in that category.
Any more questions? Annie?
We also found helmet effect in our Norwegian study 2002 on the general injury rate, on all kinds of injuries. That is a little similar.
For what?
We found that skiers skiing with a helmet had a significantly lower injury rate for all injuries.
Yeah,
and that's also difficult to explain. But could an explanation be that typically ACL-injured skier is an adult female of lower skiing ability level than average, and is it likely that that type of skier use a helmet? Well, I think no.
Yeah, the point is we saw that U-shaped function. Most of the little kids wearing it and the older people, but the people with the highest injury rate are the ones that use helmets the least. You know, in the late teenager to mid-30s is where most of the injuries occur, and they're not. So it's hard to explain, and we try all kinds of statistical gyrations. We probably haven't exhausted them all, but I can't explain it. But Aina, wear a helmet for this thing.
Yes.
I might have missed it, but in your reason for the increase in the mean days between injury for the ACL recently, did you include the line group? Or do you feel that's not significant? Do you have any data on that?
No, we have no data on that because we see almost none of them in our study. Now, if they're doing their job, it's going to take a long time to find out until the markers benefit, or they're not going to allow us to know it. We record the type of equipment, and I can't tell you we haven't seen any, or that we have seen one, but it's too early to tell because they haven't been on the market.
And if I could just follow up on that one, experience is important. And so in some of the studies we've seen, and I don't know how it is in yours, The average age of the skiing population seems to increase by 1 year every year.
Yes.
So we're dealing with the same group of skiers.
Yep. Yeah. They only turn over when they go in the box.
Yeah, the box, okay. So they're all gaining more experience. That's kind of the point you're making.
Well, if I didn't, I would understand that. What you're saying. I think that's good. Thank you.
Any more questions? Yes?
32 years ago, I just started walking, so I couldn't imagine skiing at that time. But concerning increasing number of ACL injury, is there any effect of the development of the diagnosis system, such as MRI? How do you think about that?
Well, we don't do MRI on these, and I must say that we don't do follow-up to the point of arthroscopy. This is a clinical diagnosis. If we think there's a torn ACL and we can't control the motion, it doesn't count as one. We have a category of injury where it may well be an ACL, and we aren't sure, so it isn't in that group of period. So there aren't too many of those here, and definitely not always accurate. But MRI is not an issue. I find that MRI is not even it confuses many times as that results because it's very normal with the MRI may be there when the ligament is destroyed and vice versa. I think there's nothing other than looking at it and feeling it is the only way we're ever going to know with certainty. So that hasn't been an issue. We think that we eliminated some of the first 8 years of this, a lot of the data that I gave you today, because there probably was some kind of a learning curve. We understood about the Lockman test when we started. We didn't know that was the name of it. But I bet you taught that before that by someone who didn't know who taught him. It wasn't Lockman. And so we're aware of that and taught all the folks that worked in the clinic right from 1972 how to evaluate that. I'm sure we missed one.
Any more questions? Thank you again for interesting presentation. And next, Anna, your channel?
Port Billy, Rouvière, Constant, ACL injury, 4 years of prevention campaign in France. Is it Laporte or is Binet who's going to speak? Toujours Monsieur Binet.